Hello and welcome to the Harvard Center for International Development Speaker Series. I'm Crystal Chirobo, the Program and Event Coordinator here at CID. This week's event is in partnership with the Harvard Global Health Institute. At CID, our mission is to build a thriving world for all by connecting talent, research, and practice across Harvard and around the world to tackle today's most urgent challenges. We're excited for today's conversation, A New Multilateralism for Global Health Equity. Before we begin, just a few housekeeping items. Please enjoy lunch and help us reduce waste. All food, containers, utensils, and napkins are compostable. We'll hold questions until the Q&A. I'll come around with a mic when the time comes. And a gentle reminder to make sure your questions end with a question mark. Today's session is on record and is being recorded for CID's YouTube channel with the camera on the speakers only. Photos may be taken for CID's social media. If you prefer not to appear in any, just let a team member know. Don't forget to scan the QR code around the room to check in. It helps us plan for future events. Finally, follow us on LinkedIn and Instagram at Harvard CID and sign up for our newsletter to stay connected. Thanks for being here and enjoy the event. Without further ado, I'm delighted to introduce our distinguished panelist. Alicia Ely Yamin is a leading global voice on health and human rights, serving as a lecturer on law at the Harvard Law School and director of the Global Health and Rights Project. Sakiko Fukuda-Parr, professor of international affairs at the New School, is renowned for her work on human rights development and for leading the UNDP Human Development Reports for nearly a decade. Manjari Mahajan, associate professor and co-director of the India-China Institute at the New School, explores how science, technology, and global health shape governance and equity across countries. Yanzhong Huang, professor and director of global health studies at Seton Hall University and senior fellow at the Council on Foreign Relations, brings deep expertise on China's health policy and global health security. Please join me in welcoming our speakers.
Thank you so much, Crystal. And first of all, I want to give a big thank you to the Center for International Development and to all the colleagues who have helped put this together, as well as colleagues from the Harvard Global Health Institute with whom we have been working yesterday and today on this workshop, and actually for many months of preparation. I also want to acknowledge colleagues from the Petrie Flom Center, which is co-sponsoring the work we're doing on a new multilateralism for global health equity, together with the New School in New York. So without further ado, this project really stems from as you all know, the Trump administration quickly upended not just U.S. policy and public health institutions, but also the whole global world order. And global health architecture and financing and institutions were particularly dramatically affected, are particularly dramatically affected. So this project stems from that. We had another convening in April early on when all of the implications of the Trump administration's actions were far from clear. They're still far from clear, but we have better idea of certain trend lines. And we take as a starting point, there are, of course, as many of you are very well aware, a number of different kinds of convenings and dialogues going on now about the future of global governance for health and global governance run by foundations, the Wellcome Trust, the Gates Foundation, the Rockefeller Foundation, the Clinton Global Initiative, Concordia, and on and on. We take a slightly different departure that, many of the actors who have been involved in forming the global order that we had, which was in fact deeply dysfunctional. What Trump did was catastrophic, but there were a lot of structural problems beforehand. Need to be solved through a different set of voices and ideas and imaginations than the people who are largely around the table in these kinds of convenings. So this is really a project to bring together academics and also practitioners. We have people who work on debt and tax from Eurodad, for example, from around the world, from different regions, to really think through some of those main structural issues. And some of the issues, before I go to the panelists, involve, what a new multilateralism might look like. What are the functions of a global health architecture at the global level, at the regional level, at the national level, even at the subnational level? What kinds of new financing should be explored? Should we look beyond what I'm sure you'll ask questions, but some of the models that have been proposed sort of go back to de-risking for increasing private investment, blended finance, et cetera, public-private partnerships. Are those really viable or politically appealing projects for the Global South? When people talk constantly about health sovereignty or country ownership, what does that actually mean in terms of transitioning away from aid and thinking about country ownership and domestic resource mobilization, but also in the context of increasing fiscal constraints from the shackles of sovereign debt, from illicit financial flows that take resources out of countries that could otherwise be spent on health, education, and other social endowments. And what is the role of other private actors, philanthropic foundations, corporate actors, transnational corporations, for example, in this new landscape? So with that, I will turn for very brief introductory remarks on each of their topics for the workshop. First to Manjari Mahajan to talk about some of these non-state actors and what are the questions we are asking in global health and what are the questions we have not been asking.
Thank you, Ali. So thank you for convening this panel and to Sakiko too for convening this larger project on a new multilateralism for global health. Any sort of imagination of a new multilateralism for global health, which is more equitable, which is more democratic, has to take into account the disproportionate influence that private sector actors, private actors really enjoy. And in the world of global health as it is today, the private actor, which really is the most significant, is that of the Gates Foundation. It is frequently described as having hegemonic influence, and that's not an exaggeration. For the longest time, it's been, for instance, it's been the biggest private donor to the World Health Organization. With the withdrawal of the United States, now it is the single biggest donor to the WHO. And there are many such examples, not only with the WHO, but a whole host of other global health institutions where its financial contributions are dominant. But it would be a mistake to think about the influence of the Gates Foundation primarily or purely in terms of its financial clout. It also has, in the last 25 years or so, transformed the epistemic landscape of the field of global health. So it's kind of transformed the knowledge economy of the place. And it's done this through a variety of different ways. It funds global health programs and a lot of academic work in universities like this one. It has seeded and funded institutions like the Institute for Health Metrics and Evaluation, which have supplanted the traditional role of the United Nations in producing global health metrics. It finances the work of management consulting companies, which increasingly are the go-to expertise for multilateral institutions. And so in many ways, it's kind of created a kind of common sense knowledge of ideas and narratives that are considered authoritative and legitimate in the field of global health. In the marketplace of ideas, this has meant that the ideas that actually hold traction are very few. It's narrowed the field considerably at an epistemic level. And so one of the big questions that we really have to wrestle with as we think about a new global multilateralism for global health is how to diversify, pluralize the epistemic contours of this field, and how to reduce the concentration of knowledge power in the hands of these hegemonic private actors.
Thanks so much. Turning to Yanzhong.
Thank you, Addie.
I think it's on.
Is it on? Now, okay. Thank you. Thank you, Ali and Sakiko, for inviting me to join this project. And it's a pleasure, to be here, to have a chance to speak with the future leaders. You might have heard that a zillion times, but you guys represent the future, the best and brightest, in policy studies. Really, I'm actually glad to send one of my former research assistants actually to this program this year. But she's not here. Well, another reason that drove me to this, my son is now a graduate student here, and but he also said, he has classes cannot attend this session, but. But anyway, I think this is, thanks for that opportunity, really to speak on this topic. I'm interested in the China's role in global health. What I found interesting is that September the U.S. government launched this American First Global Health Strategy. I was just looking, for whether there is any strategy, but looking from back to back, I didn't really find any strategy there. And they, basically recognize China as a growing, influence in global health, but they has no strategy to counter that influence. And it also recognized Africa, sort of a strategic priority, but it really does not mention any Chinese activities on the continent, except to mention this debt trap, the use of state actors in implementing their projects. Just one sentence mentioned that. So I found it really interesting, but clearly it's not written by AI, I can tell. Because if you just search AI, it would tell you a lot of this information should be included, right? So that's maybe the positive side. But I think we really need to we have this knowledge gap, in terms of understanding what China is doing, right, in global health, in Africa, in global South. What I found is there's a lot of myth, and there, that flies in the face of the reality. For example, we like to think, that China's health aid in Africa is essentially just like transactional quid pro quo approach, extracting their resources in exchange for health aid, this indeed, this might be some of the thinking, and maybe in some places indeed happening, but it also failed to recognize the Chinese policymakers indeed learn, right? That they if you look at Xi Jinping's global development strategy launched in 2021 during the COVID, clearly they want to move away from this transactional commercial approach to focus more on alliance building, soft power, multilateralism. B, it's about the significance of the Chinese health aid. We tend to think, the Chinese supplied a lot of this, the medical, the resources, provide a lot of resources, capabilities to Africa, global South. If you look at the data, indeed seems to show this is the case. Between, I think in the 20 years in the century, first 20 years of century, there's a significant increase of these health-related projects. Now they have more than 2,000 projects, in over 50 countries in Africa. But when you look at the size of these projects and look at the percentage of the health, these projects in terms of the value, right? The whole aid, package is actually quite small, really. So this is why China is to sort of popularize this small and beautiful, right? The projects is like maybe a counterweight to Trump's big and beautiful ones, there. And third, we'd like to think China like as a juggernaut, right? Unstoppable, influence, in global south. Well, it is, but in a way, if you think about, this rapidly rising, these sort of high-tech capabilities, AI, the biotechnology, that even us, we didn't recognize that 5 years ago, but now suddenly it becomes such a formidable force. But if you look at what actually they're doing right in Africa, global south, the human capacity gap seems to be huge. Their project seems to the big, like losing touch with the reality. They don't rely on really the communication with the local people seems to be very poor. That they don't really have this savvy, health diplomats, there, implementing the projects, that actually didn't really help projecting their soft power, So, there's a lot of myth, and when you talk with the focus on the realities on the ground. I will stop there. Thank you.
Thank you so much, Yanzhong. And I think it's the point about myths and realities about China is very well taken in this context. Sakiko, can I turn it over to you?
Yes. So thank you very much. I won't spend too much time thanking Ali for hosting all of these activities here and this event, which is a wonderful opportunity actually to hear from the students here, and I hope you'll be able to engage with us through questions. So we're trying to keep our comments very short. My focus in this project is looking at the agency of the global South. By that, what are the positions and the aspirations and the priorities that have been expressed by actors of the global South, particularly by governments, and but I want to explain that by setting this within the context of the dissatisfaction that is felt by many people working in this field of global health by the current power structures that and hierarchies, power structures, not just in terms of money, but as Manjari said, like the epistemic hierarchies of whose knowledge is legitimate and whose knowledge is ignored or even kind of suppressed or kind of attacked or erased. And so there is a decolonial discourse that is gaining momentum. I mean, there's a huge movement, in fact, of dissatisfaction that is expressed as the need to decolonize global health. And by that, we mean dismantling these power structures that mean that a very few number of governments, corporations, philanthropic donors, intellectuals, universities, and I'm sorry, we're in one of these hegemonic institutions here, but they are hegemonic actually, because it's a very small group of institutions and actors that dominate. I mean, it's not just inequality. It's a matter of domination. They set the terms, they set the rules, they set the knowledge, they set the financial allocation priorities, and so forth. And I mean, terms like country ownership is kind of a nya word that sort of say, okay, you beneficiaries, maybe you should own what we tell you to do. We need to reverse that kind of a discourse. So in this project, a number of papers are actually investigating what is the global South agenda in global health, and how is that being negotiated and politically mobilized and promoted in the spaces of international negotiations for for norms. By that I mean that the rules that regulate or set standards in global health, and a good example is in fact the pandemic treaty that is currently under negotiation, or that is just completed but still has things to do. Of course, the COVID experience is an incredible watershed moment, because it really exposed the power structures that leave countries of the global south out of access to technology, and also out of the table that is negotiating who should get what. And of course, this is something that really hits home very hard. So the work that I'm doing is looking at what the BRICS and the G20 fora tell us about that sort of thing. Other papers by Mark Eccleston-Turner here and by Lauren Paramore, who is based in South Africa, are looking at issues like how they are positioning themselves in negotiations in the WHO over the pandemic treaty. So I think it's really getting to this question as what is the role of the countries of Africa, Asia, Latin America, who have been really have historically been very persistent, actually, in fighting and contesting global rules and standards in negotiating economic and health treaties, and losing most of the time, but sometimes winning. And we're looking now at this historical moment that has a changed kind of an environment, and I think might yield different results.
Thanks very much. So I also want to make sure that people understand that this is a project. We actually have 3 more members of the workshop to whom I will acknowledge and introduce. There are a number of other people who couldn't join us in person, including some who will be very familiar to many of you. Shay Abimbola, who was the editor of BMJ Global Health, is in Australia. That made joining difficult. And Maria Jose Romero, and as Sakiko mentioned, Lauren Paramore, Katarini Storing from Oslo. So a number of other, Paulo Bus from Fiocruz in Brazil. So this is a small representation of the overall project, and we'll be very happy to share the outcomes as we produce them. I did want to introduce Emma Joanna Lengel, who is a visiting scholar here, as well as a PhD student at Oslo, who is participating in the project and working with me and Shay on how universities like Harvard shape the epistemic framework for how we understand global health and how that relates to these power asymmetries. Richard Kozel-Wright, who was at UNCTAD for many, many years and is now at SOAS and Boston University, who is looking at also at questions of Global South agency and resource mobilization, and whether, depending on multilateralism and the way it has been depended on for financing, is really feasible or viable. Mark Eccleston-Turner, to whom Sakiko referred, is looking at negotiations and norm making and the agency of Global South. So I really want to make this as participatory as possible and open it to questions from you. And I will jump in with other questions, but feel free to direct your question generally, and I will try to channel it to the right person or persons.
Hi, thank you very much. Name is Joel, a student here at HKS. I think one of the things that is just kind of on my mind is, I guess kind of one of the adages that I came across is like the road to inaction is paved with research papers. And I think when it comes to academic centers, we do a lot of research and we do a lot of kind of maybe trying to tease out very specifically what the issue is. I guess my interest is how do we move from research papers more to sort of implementation and action in a world where it seems like finance speaks more. And so how do we enable sort of these actors in the global South to sort of get to a point where they have finance, and so then you're not kind of at that hegemonic kind of tangle with these institutions.
So I actually think, Richard, this would be a great question for you to address.
You know, it's very easy to blame a system that is rigged against you, right? And the multilateral system is rigged against developing countries and has been since its inception, really. And a lot of the work that we do is an attempt to redefine, reform the rules of the game to make it more development friendly. But that should not distract from the failed efforts of a lot of developing countries to create the kind of institutional environment domestically, particularly their state structures, that are critical for the job of mobilizing resources, whether for health, whether for diversifying their economies, whether for infrastructure building more generally. And, you know, and as an institution that was set up to deal with that, we failed for 60 years to really find the institutional structures, UNCTAD. You know, and I mean, UNCTAD was set up because back in the 60s, most developing countries were commodity exporters and agrarian economies. And the job was to get out of commodity exporting and agrarian dependence into a more diversified, industrialized economy. Today, 100+ developing countries are still dependent on commodities for their sources of foreign exchange and growth. In most of these countries, a minimum of 50% of the labor force is in the informal sector, which cannot generate the kind of fiscal resources that states need to be able to deliver for their populations. Many of those countries are debt dependent. They are spending a huge amount of their resources servicing debts that have been growing significantly over so the kind of, I mean, it's a real failure because we were dealing with those problems back in the 1960s. And I don't think the World Bank and the IMF have helped. I think they've, in many respects, contributed to that problem. But it is critical to realize that there is agency in the South, but that agency needs the right kind of institutional structures for it to be directed in the right directions. And I think we need to when I think about rethinking multilateralism, I think we need to think it from the bottom up. What should that, not what resources can that system deliver, but what is the support they can provide to building the kind of institutions to allow developing countries to mobilize the resources that they need. Oh, sorry.
Thank you very much. I had a question related to, in the short term, what do you think is feasible? Because clearly, when we look at the fiscal space of most of those countries, they do not have any capability to make up for that gap. And when we look at the reports, like the Lancet one, that are like thinking about 14 million people that might die of this, I think this is even underrating because health is so interlinked with other sectors that are being underfunded right now. In the short term, out of all the actors that you've mentioned, whether it's philanthropy, whether it's private-public partnership, whether it's private, which one do you think is the most feasible and also most healthy in a way to bring in to make up for that gap in order to minimize the negative impact that that cut is going to have?
That's a great question. And there is always a trade-off between getting things done quickly and possibly contributing to further structural problems. Who wants to take that question?
Maybe I'll
yeah, go ahead, Sakiko.
Yeah, you know, I mean, you're asking a question that we don't want to answer in this in this project, because short-term answer would be to say, oh, well, maybe the Gulf states would provide extra funding, or that China would provide that funding. You know, I have, as Ali mentioned in the introduction, I worked for many years at the UN, you know, and I stopped doing project funding work because I was totally disgusted by how wasteful it all was, because all it did was to create dependency. And it was creating this dependency in such a way that it was actually disempowering people and de-skilling people, and sort of like, and so, I mean, I think that you can have these Band-Aid solutions and other people can work on these. So I don't want to contribute to that Band-Aid solution. What we are motivated by the need to find a different path, you know. I mean, obviously, if you're working for the Gates Foundation, you can find that, you know, Band-Aid solution, and I think that would be really helpful. But it's for others to think about that.
So, Mark, go ahead, and then.
So the thing that's really interesting about that question is that, you know, the hegemon is dead, and has left this sort of deficit at the World Health Organization. WHO's cutting jobs, cutting its workforce at the moment. And WHO has approached a number of the countries, a number of the BRICS countries, has approached the oil-rich Gulf states, has approached China, and asked them, can you fill this deficit that's been left by the US in WHO's budget, not in sort of global health budgets, not in bilateral, just the budget at WHO. And all of them turned around and said no. None of those countries that could quite easily fill that gap have chosen to do so. The BRICS aren't interested in doing it. China's not interested. The Gulf isn't interested in doing it. And I think that tells us something really important about what countries think leadership looks like, right? That they don't think that there is a benefit to them in terms of soft power of being the #1 donor to WHO anymore. There's a there's a power vacuum in terms of hegemonic power at WHO that no one really wants to fill. I think that tells us something about how important countries think WHO is right now. That's the more alarming question, is that lots can fill that gap and none of them are choosing to, and are choosing to do other things with their money instead.
Yeah, absolutely. I think this is when we talk about in the health capacity building, health system strengthening. Well, this is like the worst time, right? If you think about global health financing, it's a 21% drop, between 2024 and 2025 internationally, according to HME report. The thing was, the Mark said was people look to China, but in fact, I think the U.S. the retreat, it created this kind of unintended effect that provide disincentives for China, to significantly increase its like a health related development assistance, because like for a long time they used that sort of like a geopolitical instrument, right? They're competing with the US, and now the enemy is leaving the battlefield. Why do I bother to increase the health aid? So and not to mention those those BI projects, the significant investment, this infrastructural, this actually created sort of like effect of crowding out, right? Creating this debt trap, that essentially crowd out, right? This spending health sector,
I do just want to make sure in tone. I mean, I also work for Partners in Health, and we provide care in some of the poorest countries around the planet. And those countries have been absolutely devastated by the U.S. administration's decision, but also by withdrawals of reductions in aid from a number of other countries. And the millions of deaths, doing something to address that or mitigate TB, AIDS, maternal deaths is not just a band-aid solution. It's taking seriously the suffering of real human beings. I think as has been suggested, there's there is a trade-off between looking for quick money, which may come from the private sector or philanthropies in this case, and the private sector may extract certain conditionalities. The US government now, with its America First policy, is extracting significant conditions for those bilateral agreements, and thinking about the structural defects in the overall governance of global health. And we are really focused on that latter question.
This is Omar from Egypt. I was one of the team responsible for the healthcare reform in Egypt. So my question about the structural reform in the healthcare, like all of the aids when it comes to the healthcare goes for vaccination, something temporary, not the reform itself. We witnessed like shortage of finance because of what's happening right now, depending on 52 resources of financing, Japan JICA and the World Bank, and it became more politicized. So the question about for the long term, not the short term. In the developing countries, we don't need like the vaccine. Okay, Egypt be able to be the cholera-free zone like recently in this year, but when it comes to Rwanda, Burundi, this area, like they need the structural reform to be able to be independent. So what's next?
I'll be taking two more questions.
Thank you. Sorry, this would be a little bit like a comment. I'm Miklos Sochka, I'm a Mustafa Rahmani Senior Fellow here at the Kennedy School, and I was a candidate for the.
Please.
Yeah, I was a candidate for the Director General position back in 2016, and let's have the political dimension. The first question from the Chinese governmental delegation to me was not health. They asked me, what about Taiwan and One China? When I came to lobby, it was a bizarre, surreal experience when we went to the Department of Health and Social Services. That was the last day of the Obama administration. They were grilling the new secretary in the Senate. We were watching that in the lobby. And in the negotiation room, there was the secretary, the permanent deputy, and 6 people from the Ministry of, from the Agrarian Ministry. And their first question was, how would be the food recommendations of WHO influenced by a person who introduced public health product tax on added salt and sugar in my home country? So politics is one thing, money is another. I think if we simply from Massachusetts, we could put together the professional portfolio of a new alternative WHO. I don't know whether you have ever sit through a World Health Assembly. That you are killed by reading sessions. The decision-making mechanism was completely outdated. 80% of the emergency fund was empty back in 2016, and it was cross-financed from the Japanese polio fund. And everybody knew that there could be another turn in the elections, and nobody prepared for it. So we shouldn't be surprised, and there has to be an agile action. That's what I think, an agile alternative action.
Thank you very much. My name is Xiao, I'm a Master of Public Health student. I think we have been talking a lot about like multilateralism and like the need to build new institutional structures. I think my question is more of, given the dismantling of US aid earlier this year, I think we're also hearing themes of like countries moving towards more, building more of a resilient, self-sufficient health system. And so my question is, how can countries themselves seize this moment to build, a health system that works for themselves, from a systems perspective, because I think, yes, we talk a lot about financials and debt and all these global actors, but I think there's actually a lot that countries can do if they focus on the right policies on the ground. For example, focusing on primary healthcare system, ensuring that, it's not just the money or the inputs, but also you're really looking at what are we trying to achieve, right, in the context of, I don't know, towards the goals of a particular health system. Thank you.
So why don't we take a round of responses to those 3 question comments? One on what can countries alone achieve, one on the politics and financing, and one on, what was the first question? On Egypt.
And the developing country about the structural reform, how?
Yes, how to move forward, yeah.
Very, very briefly, I actually saw those 3 questions as being quite connected in terms of how they pointed to the absolute imperative for countries to break the aid dependency, the USAID dependency, and work towards building sovereign health systems. Now, it's not easy. There's clearly a financial problem, but nor is it that impossible. And I think there are parts of the world that we can learn from. There are East Asian, Southeast Asian countries, not necessarily only rich ones, Vietnam, Thailand, Cambodia, China, who did this, who didn't have the donor aid model, who invested in broad-based primary health preventive systems. And I think we forget that there are countries which have done this, and we should learn from them.
I guess I'm going to address the question about China, WHO, there's the politics. It is, I think you're absolutely right. The politics definitely maybe the litmus test if you like campaigning for WHO DG, if you want to get the Chinese support, definitely you should say we support one China principle, right? This the litmus test, but currently also, if you look at the China WHO relationship, that the main hurdle now is again political. It's the issue of like the COVID-19, the regions probe, that is making the political difficult for the China WHO relationship because WHO is continue to talk about transparency, Chinese cooperation in the regions probe. So we can't avoid this politicization in public health issues. But I think the U.S. withdrawal, and also the future sort of the phase out of the Gates Foundation, might provide opportunity, for WHO to reform itself, to be more representative, in terms, I think, for Global South to have a larger voice, in the decision-making process. Because if you look at China, it's really, even though it's sort of donated like a $500 million to the organization, there's no sign to seek dominance of the organization. In fact, I heard China's not happy. They don't have any senior Chinese, any of their citizens, taking the senior positions in the WHO, leadership team. That they would expect, they contribute money, they should have more say. That doesn't seem to be the case, to my knowledge, at least. So I think that might be sort of like like a bright side of this.
Yeah, I want to build on some of these other responses in addressing this theme of breaking the aid dependency. And I do totally agree with Manjari about the need to draw lessons from the history of building up public health systems, particularly in East and Southeast Asia. I mean, being from that region, I don't want to sound like I'm sort of trumpeting kind of a nationalistic approach to this, but I have to also express a certain level of frustration why it is that the experience of these countries has been so ignored in international discourses, you know. And I mean, I've looked at sort of the way that during COVID, the experiences of these East Asian countries were spoken about, you know, written about, analyzed in articles in places like the Lancet. It was always extremely dismissive and always extremely kind of negative. Regardless of the fact that the actual sort of numbers and facts actually tell you that the real outcomes were pretty positive in comparison with what was happening in Europe and North America. So I think that's one thing. But on breaking the financial dependency on aid, you have to go outside of the health system and look at find the solutions. You have to find the solutions to basic problems such as the debt, you know, the perpetual, you know, continuing debt that just never gets resolved, that takes up such a huge amount of, I don't know, 10%, 20% of the receipts of government in LDCs and so forth. But also other ways of financing other sources of public finance. So many of us have been arguing, for example, for many, many years that sort of something called global taxes, which is a bit of a misnomer, but taxes on financial transactions. Taxes on airline tickets has actually been implemented by a number of countries that sort of take a little bit of a levy, like $1 on an airline ticket that's paid for mostly by better off people. And that generates enormous amounts of money. At one time, I was part of a group that advocated for a tiny levy on each patent filing at the World Internet at WIPO. This kind of new forms of taxation can generate enormous amounts of resources that could finance these global needs, right? And that could replace these, you know, the charitable donations of the US government, other rich governments, other philanthropies, and so forth. And that really recognizes that there is a kind of a global interest. It's not a matter of charity, but that this is a global you know, solidarity interest. It's not even solidarity for the purposes of feeling nice about other people. It's really just the way that things are supposed to be run for the public good. And I think that's really the future. I mean, I think we need to find non-dependence creating sources of funding for these global health issues.
Great. And I know we have to wrap up. I want to emphasize something that Sakiko said. One of the really great things about this project is that not all of us are in the global health space. So we have development economists and political scientists and anthropologists and science and technical studies people, and because I think that is necessary to break with some of the orthodoxies we have seen. And so, for example, to add on to what Sakiko said, you know, looking at what countries can do for themselves, we know that primary care is the way to go. But if you say that to Lesotho or Malawi when their funding has just been drastically cut, what is primary care actually going to look like? And all of the solutions that are sort of brought from afar and imposed. Now, I lived in East Africa for years. You know, Kenya's social insurance scheme with an economy that is so heavily dependent on informal labor is just not going to work. Right? It's not going to effectively deliver care to people. So we know some of the solutions that will work, but there are also a lot of local contextual parameters, and those voices should be at the table in determining what happens next. Unfortunately, health systems are artifacts of accumulated political decisions over time, and it's very hard to undo fragmentation and atomization. Extremely difficult. So that is also a problem. So there was one last question, and then I think.
I'll keep it brief. Hi, my name is Mia. I'm a student here at the Kennedy School. I think we started off hearing a lot about various critiques and problems with the current system. I was curious if there's a framework that you all are working towards about a new multilateralism. If so, if you can talk about that. If it's not ready to be talked about yet, Professor, I think Sakiko gave us an idea that was interesting. And if you can't talk about the new framework, are there specific ideas or answers that you all think are interesting about what a new multilateralism can actually look like?
That's a complicated question. I don't think we have, we don't have one framework. In fact, I think a lot of the project is about opening up some spaces that have been closed by the way that traditional foundations and other actors are talking about these questions. So opening that up to contestation. But certainly all of us would agree on what it would meaningful agency from the global south look like. Meaningful, not rhetorical chatter. What would meaningful decolonization and democratization of global health look like? What would be a fit for purpose architecture that operates at global levels, regional levels, national levels, across maybe networks, city networks, for example, we've discussed. So those are some of the concepts that are animating this, but in general, sort of democratization and decolonization. So I know many of you have to get to class. Thank you so much for sharing your time with us and for asking these engaging questions. And we will absolutely keep CID apprised of how the project develops.